Mohit, are you ready?
Yeah, I'm ready.
Okay, so introduce yourself. So for the people who are watching on delay, which there'll be plenty, I'm sure, because the word is going to get out how brilliant this is. Uh, how did this idea start? So who are you, Mohit, and where do you live, and why are you giving people tips for new docs?
Yeah, so my name is Mohit Harsh. I am a current PGY3 at WashU in internal medicine. And in 2 weeks, I will be a chief here in internal medicine. So I'm in St. Louis, Missouri, plan on being a hospitalist after chief year. And this kind of came about honestly just through inspiration from med Twitter. I think a lot of people on Twitter give out tips for new docs, and a lot of people with a lot better advice than I can probably give, but I felt like adding in my 2 cents just because I feel so close to intern year. It was not that long ago. Um, and it just kind of started as a way for me to get my reps in on posting on Twitter. And then I think it caught on enough that we decided, let's make this into a joint effort and share our trips.
So, so is there anybody here who was your chief?
Yeah, Alonso. So Alonso was my chief.
Alonso, introduce yourself.
Hey, my name is Alonso Hudebert. I'm a junior faculty member at UAB Division of General Internal Medicine. And Mohit had the misfortune of being my intern when I was a chief resident at Washington University in St. Louis. A lot of fascination with medical education. I love this time of year when new interns are coming into the hospital. And really excited to be a part of this. And basically, I'm riding Mohit's coattails to let me get a little time in unRemarkable labs here.
And Sean, this is I guess this is your last official time as the boss.
Yeah, maybe we'll see what the future holds. But one of the outgoing chiefs at UAB, and I'll be at MUSC for rheumatology next year. And I'll be a scribe for the wisdom of the two sages and Dr. Centaur.
And we do expect you to come up with some wild cases and come back and present some wild rheumatology cases. And I'm obviously Bob Centaur, and I'm entitled to make as many snarky remarks as I want. For the people in the chat, we're going to be going over tips for new interns. Please ask questions. Sean and I will both watch the chat. We're going to start out with some soliloquies from Mohit, but after each one, we'll all sort of chip in and pat him on the back or tell him that that might work in St. Louis, but not in Birmingham or something like that. So I'm going to turn it over to Mohit to start. I do plan to talk about how to keep up when you're an intern, because I was an intern in 1975. So I started working with interns 45 years ago, and I've never heard of an intern who thought they read enough. But yet, when they become second years, they know a whole lot more than the interns. But I do have some advice for incoming interns or second year residents or medical students on how to keep up when and what reading really means. What is the right type of reading to be doing while you're a house officer, in my not very humble opinion. So Mohit, why don't you just start out with how all this started and some of the things you wanted to talk about.
Yeah. So I've been reflecting more and more, entering my chief role on what it means to be a chief, what it means to be an upcoming attending, and how to influence the residents and interns moving forward. I have Alonso's footsteps and shoes to fill. But in thinking about all this, I think I created 3 themes in my head that I think are really helpful for new interns. one of which is your own personal wellness in residency. Residency is hard, the transition's hard, so making sure that you are well to help your patients is the first and foremost thing. Enhancing clinical skills and development day in, day out is another big one. And then also patient-centered care. I think you in med school, you learn a lot of book knowledge. You start diving into the actual clinical skills and what it's like, but the patient-centered care is at the crux of everything. So I think first and foremost, wellness-wise, whether you are staying at your own institution or moving to a brand new city or moving to a different country, first celebrate yourself. Take some time to appreciate where you are going, what you're doing, and the road it took to get there. And if that means while you are in this move process, taking time to go to dinner, celebrate with family and friends, or when you enter your new city, exploring the city on your own, that's the first thing you should do, because once the ball gets rolling, it's a very fast pace in residency and an intern year, and you may not be able to slow down. So try and slow down and celebrate yourself first. The other thing in wellness, I think that is super important, is investing in the hobbies that you've already created for yourself. It's hard to keep them up even in med school, but it gets even harder in residency. So if you're someone that likes to play piano, you're someone who likes to watch sports or do art or whatever it may be, keep those up, because those are things that will bring you joy outside of medicine, and hopefully will enhance your ability to care for patients. And then the other big thing, wellness-wise, to start off the bat, I think is exercise. Even if it is just walking, it's better than nothing. You'll underestimate the amount of time you're actually sitting as a resident, the amount of time you're at a computer. Make sure you take time to even walk 10, 15 minutes a day. I make sure that happens every day by when I park my car. We have about a 15-minute walk from where we park to where the actual call rooms are. I make sure to be outside and walk both in and out of work. So it's those small things that make a difference. I'll stop there and let Uncle Bob or someone else reflect on this.
Well, I really love that, Mohit. When I think back to internship, and I really have to think back because I was an intern before any of y'all were born, and that really was a long time ago. But I was an addicted basketball player, and we used to work, the famous 34 hours in a row. Now, I almost always got a couple hours of sleep, but I would come home, and I was on every third night as an intern, and I would come home on my off nights and find an opportunity to play basketball for half an hour to an hour. I'd find time to read a book, listen to some music, and then crash. But I did things for myself exactly like you said, and I think that really helped me stay upbeat throughout internship. Even though I was working very hard, I always was doing those things to take care of myself. And that's really, really good advice. Alonso, what are your thoughts when you think back to internship?
Yeah, I think and I think these are wonderful points. And I think the only thing I would want to add from a wellness perspective is something really kind of special and magical happens when you go from being a medical student to being an intern. That kind of responsibility you have for the patient, you really start to feel it for the first time in your career. And when you're an intern, you tend to be working in a team with other interns. So just a couple of thoughts I want to throw out from a wellness perspective is, one, while you're celebrating yourself and investing in your hobbies, invest in the people around you. Invest in your fellow interns, and invest in your senior residents, because these are the folks that are going to teach you some of the most information you're going to learn while you're in the hospital. These are the folks you're going to rely on These are the folks you're going to celebrate your amazing moments with, and these are the folks you're actually going to turn to when things go sideways or things are rough. So, you know, I just think about the pitfalls I see with interns, and one of them is isolating yourself, trying to get too focused on getting out of the hospital, or trying to get too focused on, you know, minimizing time in the hospital, and instead really invest in the people around you, because they're really going to make the experience something special. It's a time of remarkable growth for you, not only kind of in your clinical sensibilities, but in yourself as a person. And then just the other part I would put on wellness would be, you know, I think it's really important to do stuff outside of the hospital, but I think it's really important to also have a mentality where it's not work-life balance in the sense that work is this negative thing and your life is all this positive stuff, and you want to put all this positive stuff on here so that this sucky part doesn't suck so much. Like, I think if you can make it so that you're enjoying yourself in the hospital, and I think part of that is really, again, investing in the people around you and really dedicating this time that you have to your craft, just elevates the whole experience.
Sean, you actually worked with me when you're an intern, and you survived that. Do you have anything to add to this? And does anybody have any questions about this particular subject before we go on to the next subject? While Sean's talking, please put them in the chat.
Eamon said something in the chat that I think is pretty important to actually just say out loud, but it is important to find joy in your job and the people that you work with. There's a book called Leaders Eat Last. That's a pretty good book. I haven't finished it, so I don't know if I can 100% recommend it. But it talks about how basically on a team, the team functions better and people are happier if everybody on the team knows that they don't have to worry about being attacked by other people on the team. And I think that gets 100% with what Eamon and Dr. Hudbert were saying about recognizing that this is a team sport, and you're going to have to play nice in the sandbox, but you can also, like, these are going to be some of your best friends, because residency is kind of a couple-year process. You're going to meet a lot of people. In medicine, we have huge residencies, but I mean, I know other like residencies are a lot smaller. So no matter who it is, try to make an effort to know your co-residents, and really recognize kind of the types of things that make you happy, and don't forget about them, because it's so easy to forget about them when you're working 80-hour weeks. So I definitely agree with what Mohit is mentioning about investing in your hobbies.
Great. Mohit, do you have any final words on that subject?
Yeah, I think that's a really critical point. I think Alonso's point is well taken. He said something similar when he was the chief to me, that if you think of work as a negative thing, you end up trying to find ways to leave early, not do as much effort, not really invest in the time that you are there at work. But always reflect back, no matter how difficult intern year and residency can be, that you chose to be a doctor for probably a very good reason, and that is to help people. That is because you enjoy medicine for what it is, and always keep that to your core, because that will be the guiding light when challenges face you. That'll be the guiding light when you are on a 28-hour shift and you're very tired. And as much as there is joy outside of medicine, there is a lot of joy in medicine, and keeping that close to you is super important to prevent burnout, to keep longevity through and through, such that you can still be attending 45 plus years out.
So an implicit theme through here is not only you're taking care of yourself, but you're taking care of your colleagues. And so you're there for your colleagues. And one of the most wonderful things is the support that I see interns and residents give to each other. And I've seen this for years and years and years, because I've been fortunate to be at programs where there is a sense of camaraderie and healthy interaction. I just hope everybody has that and has really good friends in their residency, and just the joy of something good happening to a patient, being able to share it with someone just makes your life so much better. So I think all the wellness stuff is really important. And I think it's different at different institutions, and you sort of have to find your way at your particular institution. But it's really, really good. So Mohit, why don't we move to tip number 2?
Yeah. So enhancing clinical skills. I thought of this in a couple ways. One is how you keep up with new information, how you learn in residency, but then also just things that you may not really recognize as a med student that become really, really important in patient care. So if you're on this chat, I'm probably preaching to the choir, but there's so much free online medical education out there. Use it. Whether it's through Twitter, whether it's through these Zoom meetings, the clinical problem solvers, blog sites, you name it. It can really, really enhance the way that you think about patients, the way that you think about medicine, because some really bright people, thankfully, put down their thoughts, either pen to paper or on keyboard to their website, and it's nice to get that on top of the already structured didactics that you get in your residency, and then layered on top of the one-to-one teaching that you get with your senior residents, with your co-interns, with your attending on service. So that's one big plug for me, and that's something that I really invested in probably halfway through intern year once I got my bearings, and I haven't looked back since. I recommend it to everyone that utilize free online access to education. The other big thing that is super important, and I got this from Gurpreet Dhaliwal, is keeping an interesting patient list, or keeping an interesting patient list and keeping a list of patients to follow up on their clinical course. The reason why that is say you do an emergency medicine shift, and there's a patient who comes in with dyspnea, you admit them to the floor, and then you have seen 10, 15 other patients after. You don't know unless you track back a couple days later, was your initial thought that this is heart failure exacerbation or COPD or whatever it may be, if it was true, and what that outcome was. So unless you follow up, you won't know. And the other thing is, the interesting patient list is important because it's hard to keep details straight. 3 months, 4 months down the line, you may remember, oh, I had a really interesting case, but the details are lost on me. If you want to learn later on from that case or teach others with that case, you should keep a list of that. And my list now just continues to grow. I think every month I add 3 or 4 patients, and I look back on their care, and it enhances my ability to help the next patient. The other big thing, I think, is in that same realm, doing a cognitive autopsy and discussing patient care with colleagues, whether that be your co-interns, your residents, or your attending, running things by, not necessarily for direct patient care, but after the fact. You have a case of hypercalcemia and you just want an endocrinologist's thought on it. Making sure that you have those conversations almost as an academic pursuit, so that enhances your ability to care for the next person with hypercalcemia, or you learn tricks of the trade from an endocrinologist's point of view.
So this is probably where I should talk about reading. And this is the advice I've been giving to students and interns for many years now. And I do it at the end of rounds. So at the end of rounds, I say, okay, what 2 things did you learn today that you want to remember? And I used to just do that. And then something happened, and about a week later, I asked some students something that I had taught brilliantly. At least I thought I'd taught it brilliantly, but they hadn't learned it. I had to reteach it. And it made me realize that as a teacher of medicine, my job is to induce learning. So what I need to do is trick you into learning. And the way I trick you into learning is teaching you something, getting you to write down that you learned it, and convincing you to spend 5 minutes reading about it. And so as an intern, you can't sit there. Most people can't sit there and read Harrison's or read Cecil's or read Up to Date. But you can, if you have a patient, we had a patient in our service who we believe has a type 4 RTA. Let's say you didn't know anything about type 4 RTA and we discussed type 4 RTA on rounds. Sometime later that day, spend 4 or 5 minutes reading about type 4 RTA, because neuroscience tells you that if you hear something and then you read about it, you're more likely to remember if you just did one. Another great way, which Mohit has already discussed, is listening to really good podcasts. So I listened to a really good podcast today from the Curious Clinicians. It was why when you give IV furosemide to someone with pulmonary edema, they feel better before they pee. I was actually taught that in 1975. And I thought I sort of knew it, but it was really good to listen to them talk about it for about 20 minutes this morning, and sort of reinforced, and it gave me something that I could use as a teacher. And anytime you can connect something that you see with either a tutorial or a podcast, or a really good article, you'll start to own it. And you're much more likely to own it if it was your patient. But if you're an intern and there are 2 interns on the team, pay attention to the other intern also, because they're going to have interesting things, and find some time to discuss it, or sit down with your residents, say, I really didn't understand that. Or don't be embarrassed to tell your attending, I don't really understand what's going on. Now, some attendings won't do that in the right way, but most attendings will understand that if I have an intern say, I don't understand why we're doing this. So it could be that I don't understand either, but the biggest thing is most of the time I'm going to be happy to try to make sure that the intern understands. So read about your patients. Don't try to read too much, but try to read a little bit every day, just a little bit. If you read a little bit every day, you'll be amazed how much you learn in a year. And find some good podcasts to listen to. I highly recommend Annals on Call because it's really brilliant. But no, the Curbsiders is great. Clinical Problem Solvers is great. Curious Clinicians, etc. Alonso.
Yeah, I think these are all incredible points, and I think the only stuff I would follow up on enhancing clinical skills is have a couple of quick comments. One, I'm going to read the room here and think that we have probably a lot of folks that are very dedicated, very interested, probably high achievers who are spending 7 p.m. on a Tuesday to learn how to be the best intern they can be. So the first thing I'll say is working on your clinical skills is so important, and there's going to be, and just like that should be the key focus of your intern year. And there's going to be a lot of folks who at some point feel like they should be doing other things, publishing, community outreach, whatever. And it's a wonderful thing if you can do, but it's okay. It's okay to just dive into this. And it's okay to feel a little overwhelmed when you first get there. I went to an amazing smaller medical school, had a wonderful time. When I got to WashU, it was a little overwhelming. And for a while there, I felt like, I should be doing other things. And then I realized just, what, it's really important to just in that moment, focus on on that skill acquisition. The only other thing I would add, I'm a huge proponent of the follow-up list on when you're on night float, that sort of thing. It's really important to follow up on those things. In line with that, no matter how hover hands your resident is, always try to make sure that you are coming up with a plan before you talk to your resident. You see a patient, you come up with a diagnosis and what you want to do about it, and then get feedback back on that, because that's how you learn, is in really committing.
So Travis Smith wants to ask me a question. It might be about golf, but it might be about this. So Travis.
Everything ties back to golf. That's where all the deals are made on the course. So, I think the question too could be, from all of you who are, residents as well, I think your feedback is something that, can help. I think students now they have so many different ways to learn, and it's different one than when Dr. Centaur, started, as far as how many, books or materials there were to read. When I graduated medical school in 2009, and, when I was in school, maybe I did a question bank, not too much. I mean, UWorld was, we did some questions, but it wasn't like the big thing, a little first aid. But, I read the Washington manual, all the specialties, and like, I enjoyed reading those. And then in residency in emergency medicine, I read Tintinelli's. That's what we read. That was our textbook, and maybe a review book here. But now, just with students, because I work with 3rd and 4th year students, and you guys, I'm sure, see it all over Twitter, is students are reading Sketchy. They're reading all of these. They're using all of these different learning tools, just for memorizing facts so they can do well on boards. And I try to get my learners to read. I try to incorporate in the clinic articles and things like that for when they're on their rotations. Like, hey, read this, is good clinical application, rather than just doing, a memorization flashcard. What do you guys, how are you kind of bridging the interns to reading, articles and practice guidelines versus them, looking at and doing Anki decks and flashcards and question banks? Because I feel like they're not used to reading. They don't want to read a textbook or a review article. I mean, are you finding that with interns in second years?
I'll often send an article to the team if it's relevant. We actually had a question come up yesterday about whether we could believe the ejection fraction from a Sestamib stress test as opposed to getting an echo. So I found an article and sent it to the team, and it turns out it's a little bit better than the echo. But I think that it's our responsibility as attendings to periodically find articles that make sense, but also encourage interns, residents, and students to look up an article. See, can you find something that helps us with that, and reward people who do that. And Alex Smith wants to know if the learning pattern should change as a PGY2. The biggest thing that happens at PGY2 is you're exposed to even more patients, so you have even more stuff to read about. But it's really reading about your patients in depth and reading about what you learn at conferences. So going to morning reports, and when there's an interesting case, read about that interesting case if that's the most exciting thing that you heard that day. I learned a lot from all the chief residents that I try to learn new stuff like that all the time. Sean, do you have thoughts about this?
Yeah. So for me personally, like, I enjoy learning when it's kind of driven by one of two things. Either it's helping me out with the person I'm taking care of at the hospital right now, or I think it's something just interesting. And so basically, whenever I sit down to have like my learning time, which could either be reading or watching something, the first thing I ask myself is, what patient did I take care of today? Was I uncomfortable with their care? And if I was uncomfortable with something, then I start looking up primary articles, review articles, trying to answer whatever I was uncomfortable with. And then if it's when I finish kind of that time and it's something fun, I think about kind of the things that I've seen over the last couple of days or what I'd like to do in the future, be in rheumatology. And then I kind of go after that kind of stuff. And I keep track of what I basically try to learn on a day-to-day basis, so that, you know, in maybe 2 weeks, I can come back and circle back around and I'll see, oh, 2 weeks ago, I read about Sjogren's. What do I remember about Sjogren's? And then I kind of ask myself those questions and make sure that I actually did kind of cement that knowledge.
Mohit, you get to wrap this one up.
Yeah, I think Travis's question is a really important one, because especially in your third and fourth year of medical school, you have almost two competing interests. You have the clinical skills development, the real world gray zone that is medicine that we try to teach, that will actually impact patient care day to day and make you a better intern, make you a better resident. And then you have the board exams, the shelves, and all this stuff where everything's very black and white, and you just need to know textbook knowledge. And with that, I think, you know, especially now, even when I was a med student, there were a handful of things that we used. There was Pathoma, UWorld, and Sketchy Micro, first aid. And I feel like every year there's just more and more and more of this free online education, or even paid education that you can get. And it comes with a double-edged sword. It's great, you have all these resources, but then it's also very overwhelming, and to know which one to really access as a student is very overwhelming. So what I try to do is do a little bit of both. I say heart failure. I do a little chalk talk on things I know are going to show up on the shelf. Give them resources that I know are really related to their tests, but then curate an email or a text or whatever with resources that I've already read and personally find helpful, and say, you should look into this. So one example is like the Internet Book for Critical Care. I love that resource. It's very evidence-based, it's very practical. So I will not only talk to them about what's going to be relevant for their exam, but then say, hey, if you want really in-depth stuff about heart failure management in a critical care setting, check out this blog post or check out this podcast. And I think that helps, because if you are unguided in this process, it's very hard to find and kind of quantify which resource is best, which resource is appraised to be the most evidence-based or most useful. It's easier when residents or attendings kind of guide you through that. And then the question in the chat about is the, you know, learning different as a PGY2 or PGY3. I think PGY1 is very much knowing what to do, knowing what orders to put in, knowing just almost the stepwise approach to everything. PGY 2 and 3, you should really focus on why we do those things. And when you focus more on the why, then you can start learning more and more that there are some things that we have great evidence for. There are some things that we don't really have great evidence for, and they should be treated kind of differently. And that will then enhance kind of what we're getting into next with the patient-centered care, is how do you end up dealing with all the gray zones when the world is not so black and white? And how do you handle shared decision making when there's not great evidence, or regardless of how you skin the cat, there is a risk with it. So in the end of the day, I think it is our responsibility as residents, our responsibility as attendings, to guide students on what resources we find helpful, while also balancing what they actually are stressed about, which is getting through the shelves, getting through these tests through medical school. I don't know, Travis, if that helped your question.
And if I can add just a little bit to that, and mostly just repeating a lot of what Mohit said, but Travis really isolated a beautiful tension in that in medical school, things like Anki, like data, like card sets that help you quickly memorize answers and be able to respond to keywords and key phrases, is an incredibly powerful tool that really helps you succeed in medical school. But it doesn't work as well by itself when you become an intern. I think that's what we always try to sell people when we're teaching them on the floors. But if I was to give any pointed advice for interns coming in is to start thinking about things mechanistically and start thinking about things as it relates to the evidence. Because it's not going to be as clear cut as it was on the tests. And I know, Dr. Center, you can give 12 different examples where knowing good pathophysiology, knowing the way mechanistically things work, can lead you to the answer. So revisiting some of that stuff that sounded really arcane and useless that you learned in the first couple of years can actually really help your clinical reasoning once you hit the floor.
Yeah.
Great. So let's go to patient-centered care. Shouldn't all care be patient-centered?
It should be. It should be. I think the big difference in med school going to residency and intern year is in med school, there's this constant drive that I need to perform. I need to look well in front of my team. I need to look well in front of the attending. And in residency, like Alonso alluded to, this is the first time that you're taking a lot of ownership for your patients and you are having a direct influence on their outcomes. So you need to get rid of this mentality that I'm not going to look good in front of an attending if I don't know the answer. I'm not going to look good if I have to ask what to do next. In the end of the day, always tie back in everything that you're doing to your patient. Your patient should be your primary motivator, which will then enhance your clinical skills, which will then hopefully trickle down to helping your wellness, because you will always remember that the crux of what you're doing is patient care. And I think that is the biggest theme with patient-centered care. There's more specifics that I'll talk about, but I think that if you keep that at your heart, that is the key thing. The one thing that I really invested in thinking about in residency that really shaped the way I think about patients is that you should do things, be it a medication, be it a surgery, be it a procedure, whatever it may be, only if it positively impacts their quantity or quality of life. And if you can't justifiably or give evidence that it will, you really need to rethink if you're doing that. And I think that is where patient-centered care really comes about. A lot of times we do things for defensive medicine, or we do things because culturally that's what we're told to do, or that's what the institution does. But when you start digging into why we do these things, always think about, are we doing these things for the benefit of the patient? And with that, you need to be able to, in patient-centered care, have those conversations, be able to have shared decision-making conversations. They're hard to do, and you can ask for feedback. Have your attending or have your senior resident listen in on the conversations. When you step out of the room, ask, did I explain that properly? Did that make sense? I think that's another big driver, because like we were talking about, med school, you think everything's black and white. In real life, everything's gray. Being able to educate your patient on the risks and benefits of whatever you are thinking of doing is super critical to your day-to-day work. And even if that is, we think this is the best thing for you, and trying to convince them of that, that's one thing. But then also when it really is the patient's decision to make, being able to guide them through that, just like we guide our learners, is super important. Yeah, go ahead, Dr.
Yeah, I'm gonna pile on, because I always pile on. Osler apparently once said, "The good physician treats the disease. The great physician treats the patient who has a disease." And this has something to do with wellness also. Whenever you have time, and you should make time for this, get away from the computer sometimes and find out who the patient is. Find out what their story is. It's amazing, some of the stories that we have. And I work at a VA mostly, and some of the most incredible patients, incredible stories about their life, about what they did in the service, what they did after the service, which changes the whole way we look at trying to develop a plan for a person rather than for a disease. And it's really easy to get disease oriented. And I'm guilty of that. And I think everybody who's talking about this, we sometimes get fascinated by the disease. Remember, it's not a great case unless the patient benefits. It's an interesting case, but it's only a great case if by making the diagnosis and getting to the correct treatment, the patient benefits. That's a mindset that will help you with your wellness, but it also will help you through patient-centered care. And I'd love for you to see if I was getting at some of what you were trying to say, Mohit.
Absolutely. I think you very succinctly said what I was kind of belaboring the point on. In fact, there was something I was going to add. So my old program director, Dr. Blanchard, when I had him on service, he had one quirk about him, and it actually stuck with me, that whenever you admit a new patient, whenever we would present to him, we would have to present first something interesting about the patient, be it what they're interested in, what their background is, whatever it may be, before you even get into their diseases and before you get into what is bringing them in the hospital. And I think that really resonated with me and goes to your point that in the end of the day, you're treating people, you're not treating a disease. And the more and more that you can learn about the patient's values, the patient's interests, the patient's life, the more educated you are to then help them make the decisions and help guide them through very challenging life situations that bring them in the hospital. With all that, we can get pretty granular, but some things related to patient-centered care that I think are super important. Start thinking about value-based care as well. Let your patients sleep if you can. Sleep is the ultimate healer, and I think we forget that in the hospital. And one big thing that I tweeted about recently, but I think is important to mention here, is non-adherence to medications is and should be treated as a diagnosis of exclusion and should also have its own differential to it. So what I mean by that is when you label someone as non-adherent to medications, that label sticks with them and it gets passed on patient or resident to resident, generation to generation who have taken care of this patient that historically they are non-adherent. You should really try to tease out what is causing them to not take their medications. Is it something that we are doing a poor job of explaining, that our medical reconciliation is not great at discharge and that's what caused them to not get their meds? Was it a financial burden that they weren't able to get their meds? Was it just an emotional toll that they're on too many pills? There's a lot of granular points I can bring up, but that's one I wanted to just mention because I think that that's something that really irks me when I see it, and no one really explains further on what is causing them to be non-adherent and if they truly are non-adherent.
Alonso, apparently you were a great chief resident because you took Mohit from, it's sort of like taking a tabula rasa and look what he's become.
Yeah, I think Mohit's way more responsible for all of this than I had, but I'm glad to have been a part of it. I just want to add my 2 cents. I want to add one pitfall to talk about that's I think tangentially related to this, and then the one thing that I recommended to Mohit and his entire class when they started out, and I think is still relevant and helpful for a house officer today. Like Mohit said, and again, why I think residency is so special is that you're transitioning from a very me-centered education in medical school and undergrad to a very patient-centered and team-centered approach to the care of the patient. And you need to always remember that, and you need to keep it close to your heart. But the pitfall I want to talk about, and what you guys who are starting to really get into the hospital are going to see, is you have to let yourself feel what's going on with the patient. You can't let yourself become so calloused that you don't feel what's going on with the patient, but you also have to be able to function. So there's this really kind of delicate walk you have to do between these two extremes, where if you're not feeling or understanding what the patient is going through or trying to, then you're not doing your job as a physician. But if you can't walk out of that room and then go take care of the next patient that's going through some horrible things, you're not doing the job either. So I'd love for you guys to reflect on how you found that balance. It took me a little while to get there, but to never let yourself get too calloused or feel everything to the point where you can't take care of the patient, because in feeling and empathizing with the patient is when you really will deliver that top quality care. And then my last point, and just something that I recommend to every intern as soon as they get to the hospital, is and this is again bringing you back to the bedside and bringing you back to the patient, is what I like to call social rounds. So you have your kind of morning, you look up the patient, come up with the plan, talk to your resident, attending comes by, and you do your actual medical rounds. Then you guys go off, put in orders, go to conference. And what I used to do at the end of every day, right before I was going to sign my list out, is I would walk to every patient on my service, assuming the ones that were in close geographical connection, because you can't walk all the way across the hospital. Sometimes you're a little too busy. And I went there with very little agenda. I just went in there to check in, see how their day was doing, see if there's anything left that that I could do for them, and let them know that I was leaving for the evening. And I'll tell you, not only did I think it cut down probably 30% of the cross cover calls that would have come to the covering resident, which I think was always appreciated. It let me be in the room with the patient without an overarching agenda and really get to spend time with them without thinking about, I have my next patient, we got to finish before conference, we have these orders to put in, I got to get this discharge in. All that stuff had been tucked away. So it really let me just be in the room. And it's something that I know it sounds like a big time commitment for your day, but you don't have to be there very long, couple of minutes. And I think it'll keep you centered on your patient. It'll keep you feeling what's going on with your patient. And I swear was a great source of wellness for me in my time in the hospital.
Sean, do you have any thoughts? I mean, these two guys are pretty brilliant. It's kind of hard to add anything.
Yeah, I was afraid you would call on me because I've been racking my brains and I'm like, these guys are crushing it. I'm not sure if there's anything else I would say. But I kind of remember, so Dr. Willett is our program director here at UAB. And one of the things she says to everybody, if you're ever on her service, is if you're doing something for the patient, you're never wrong. So remember, when you call that consult, that you're not sure like if you should actually call, if you're calling it for the good of the patient, you're never wrong. It's not a bad consult to call. Don't apologize for calling that consult when you call it. If something just feels wrong about the discharge, or if there's some sort of problem, or there's like a new symptom that's coming up. Like I remember this one patient on oncology who had a pretty advanced cancer and had a horrible course. And on what was supposed to be her day of discharge, she started having pretty bad nausea, but she was like, I think I can still go home. And I was like, well, let's just see kind of what happens. And it started getting worse. She couldn't keep down any food. And so I canceled her discharge and got a CT of her abdomen, and she had a high-grade bowel obstruction. And recognizing that, hey, like that's not always going to be the case when you have somebody complain of nausea in your service, but really focusing on, okay, for this patient, would it be helpful if we kind of just wait a little bit extra longer? I swing back around, do a social visit. That will help out their care so much, and it can help out your wellness, because you're going to feel more fulfilled when your patients feel more fulfilled. Like I promise you, if you put them as your goal, they're going to thank you and appreciate you throughout their time with you. So they said it better than I could. But
so Mohit, you reminded me of something that I often teach when I'm on service, and that is my favorite question. And my favorite question, and this was especially true when I did outpatient medicine, is what do you do for fun? And the reason that's such a great question is because you're screening for depression. And periodically people say, I don't have fun. And then you go down the depression track. But if they tell you what they do for fun, then you have that sort of, as you said, your program director told you about, and that's something to ask them about each time they come in, if they're your outpatients, or it's something to just sit down and chat with them about for a few minutes. And it's amazing the change in the expression of the patient's face when you find out that they're a basketball fan and you're a basketball fan, you talk a little bit about basketball, and then you go back to the disease, and it's like, this guy really cares about me because this guy is concerned about what I'm concerned about. And that human link, and that's about getting to know your patient. That's another question. And if you've never purposefully used that question, I strongly suggest that you just try asking patients, what do you do for fun? You'll be amazed at how much depression you diagnose that way with anhedonia. But I don't know if that makes sense, Mohit.
No, it definitely does. And something that I had written down to make sure to bring up as well, it kind of ties all this together, is whether you're treating a patient on the outpatient side and in a clinic appointment, you are admitting someone from the emergency room, or you are getting a patient from the ICU, whatever it may be. By the end of your intern year, you will have seen countless patients. You won't be able to even remember the faces of every one of them because you've seen so many. And it, the work initially is hard, the transition is hard, but I promise you by the end of it, you will be doing things like it's the back of your hand. And it'll seem mundane at times to you, that what you're doing is mundane because you understand everything. You know how to admit patients. You know how to work up certain certain conditions, but it's never mundane to the patient. Their admission is a big hit on their life. Their ICU stay was traumatizing to them. Their their clinic visit to discuss the results of whatever scan you may have ordered or whatever labs you got, or discussing their new diabetes diagnosis is a big toll on them. And always remember that. If you can remember that, then it will always bring you again grounded and centered to, this is really impactful for patients. I need to treat them with the respect they deserve, and I need to treat them with the empathy that they deserve, because this may have been my 100th diabetes talk just in the past month, but for them, this is the first time they're hearing that they have diabetes.
Well, I think that's a great way to finish. Mohit, you really gave us a great opportunity. I hope that many incoming interns will watch the YouTube video and learn a lot from it. I hope the people in the audience learn a great deal. If you have any last minute questions, please type them in. If you'd like to applaud Mohit, please write that down, because we wouldn't have had this without Mohit's tweets and his thoughtfulness about how to prepare his incoming interns.
Well, thank you so much.